Hello, I'm Deeksha, and I'll be presenting our work on developing a deep learning framework for multi-level seizure onset prediction from scalp EEG data. Epilepsy is a debilitating neurological disorder characterized by multiple recurring seizures. It is classified into focal and generalized epilepsy depending on seizure onset characteristics. According to a study conducting active point prevalence, 37% of the patients have focal seizure onset. Focal epilepsy is known to have higher risk of sudden death. Moreover, nearly one-third of the patients are drug resistant, in which case the best alternative is to surgically resect the defected brain region. The success of the surgery depends on the efficacy of localizing this brain region beforehand in the pre-surgical workup, which is an extensive process. It begins with the screening step for focal epileptic patients who undergo a series of neuroimaging procedures to identify epileptic zones. It is followed by invasive mapping of the affected area to precisely localize seizure onset zone. Invasive mapping is not only highly risk-prone, but also has a narrow field of vision within the implantation area, limiting its capabilities. As an alternative, we aim to employ computer-aided tools using neuroimaging data to assist the clinicians with the pre-surgical workup. We use scalp EEG-based AI algorithms to streamline the process and augment knowledge base before invasive procedures. The current gold standard with EEG involves hour-long inspection of the signals by expert neurologists. This is a challenging task due to the noisy nature of the data. As you can see here, most salient features in the signals are mostly artifacts, while the seizure characteristics are more subtle. Several efforts have been made to overcome the challenges using computer-aided tools. Existing tools, however, almost exclusively focus on the task of predicting temporal seizure onset. At the same time, however, it's more important to also localize seizure onset zone SOZ, particularly for focal and drug-resistant epilepsy. Inspired by the success of deep learning in several existing areas, we propose a deep model to simultaneously detect and localize seizure onset from multi-channel scalp EEG data. Our model, DeepSOZ, has three main components: an encoder, a detection branch, and a localization branch. The encoder processes each 19-channel EEG XT of 1 second long time window to generate multiscale encodings, a global encoding H0, and channel-wise encodings H1 to 19 at T for downstream tasks. The encoder itself comprises of a transformer that leverages self-attention mechanism to fuse cross-channel information. This attention allows the model to focus more on seizure-relevant channels to extract meaningful encodings. Additionally, positional encodings are added to the input signal to distinguish channels. This step informs the model to learn similar encodings for neighboring channels in the brain. The global and channel-wise encodings from the transformer is now fed into the detection and localization branches respectively. The detection branch consists of a bidirectional LSTM that processes H0 across time to output the posterior on temporal seizure occurrence S hat. Finally, in the third branch, we obtain the posterior on spatial SOZ vector Y hat using a smart pooling technique across time. We use the predicted seizure probability for the weighted average, which weighs the channel-wise encodings belonging to the seizure period higher. This way, the model avoids false SOZ predictions arising from artifacts. We train DeepSOZ in 2 stages in our multitask learning setup. In the first step, we use a weighted cross-entropy loss for window-wise temporal seizure detection to push the predicted probability closer to the ground truth binary labels all across time. In the second stage, we fine-tune our model for SOZ localization. The loss function comprises of a similar channel-wise cross-entropy term comparing Y hat and ground truth Y, and a term to prevent catastrophic forgetting of detection learned in the previous step. Additionally, a sparsity constraint on Y hat is imposed to encourage the model to pick fewer channels as one would expect in focal seizures. We train and evaluate our model on a dataset of 120 patients with clear focal onset selected from the publicly available Temple University Hospital corpus. The temporal onset is clearly available while we derive SOZ labels by perusing the associated clinician's notes for the patient. The dataset has an average of 14.7 seizures per patient with at least one and as many as 152 recurring seizures. The seizures can be short bursts or longer ones reaching status epilepticus, ranging between 7.5 seconds and about 18 minutes and averaging at around 1.5 minutes. Majority of the patients, 72 of them, have temporal lobe epilepsy while maintaining a balanced right and left hemisphere onsets. We evaluate DeepSOZ at multiple stages to establish its robustness. We evaluate detection performance at the window level to quantify granular performance capacity of the model. We report AU-ROC score, sensitivity, and specificity. At the seizure level, we assess overall performance by looking into full recordings. We quantify sensitivity as the average number of seizures detected, amount of false positives in minutes per hour, and latency as the delay in detecting temporal onset in seconds. Similarly, we evaluate SOZ localization in 2 levels. At the seizure level, we do M Monte Carlo forward passes of the same recording to generate M Y-hat samples. This helps us evaluate the consistency of the model's prediction for the same input recording. At the patient level, we consider N recurring seizures of the same patient. This helps us evaluate the model's consistency across multiple seizures and track propagation of the seizure over time. In both levels, we take average across the samples for final aggregate prediction. It would look something like this, for example, for a patient with right posterior onset. A seizure is correctly localized as marked in green if the maximum channel in the predicted Y-hat lies within the true onset boundary. We report the accuracy in both levels and quantify uncertainty as the total variance of the in Y-hat samples, and we report intra-seizure and intra-patient uncertainty. We report the average metrics across repeated 5-fold cross-validation. We observe that DeepSOZ outperforms all baselines in window-level AU-ROC score, achieving a good trade-off between specificity and sensitivity. At the seizure level, it has the least false positive rate while maintaining good sensitivity. In SOZ localization, DeepSOZ achieves the highest accuracy among all models while maintaining acceptable uncertainty levels. In order to get a better idea of DeepSOZ's performance in localization, we aggregate the final predictions of DeepSOZ of all 120 patients into regions, namely left versus right and anterior versus posterior. As seen in the confusion matrices, DeepSOZ is adept at differentiating right versus left hemisphere, but struggles to differentiate anterior versus posterior SOZs. We hypothesize that this trend is due to the skew towards temporal epilepsy patients as seen in the TUH dataset. Here are some correct final SOZ predictions by DeepSOZ. We observe that the model correctly localizes seizure from all lobes with a high resolution down to every EEG channel. On right, we plot some incorrect predictions. We observe that in most cases, even when wrong, it is within the right hemisphere, as in correct hemisphere, or a secondary mode is seen in the true onset region. Here we visualize the performance of DeepSOZ for one patient. The temporal prediction is plotted on top, where we observe that the seizure is detected with some false positives. In the bottom, we plot the predicted SOZ vector on a topological head plot. The model correctly localizes the predicted SOZ to the left frontal lobe. In the second and third seizure, the temporal onset is detected accurately, while SOZ prediction includes some false positives. This model is confident of the final SOZ prediction as shown in the right with much lower uncertainty levels. In another patient, DeepSOZ is accurate about the temporal seizure detection. However, SOZ localization spreads from the right posterior quadrant to the left hemisphere in later seizures. We refer to the clinician's notes to find that the seizure indeed spreads, and DeepSOZ managed to capture it without being trained to do so. The final SOZ is hence more diffused, increasing the uncertainty levels for the patient. The secondary modes in the final prediction indicate the need for further investigation using full brain imaging modalities such as MRI. In conclusion, we have developed a deep learning framework for multi-level seizure onset prediction with minimal risk. It provides informative predictions from scalp EEG to help clinicians with quicker and more accurate decisions. Beyond predictive performance, we quantify the prediction uncertainty to establish its trust to integration into the workflow for epilepsy. Thank you.